This presentation will be presented by occupational therapy students Danielle, Justin, and Blake. The purpose of this presentation is to elaborate on the template that we have provided for dysphagia. There will be various aspects of dysphagia touched upon, such as what it is, the process of swallowing, the types of dysphagia, and some of the conditions associated with it, also known as the comorbidities. We will also discuss some of the precautions and contraindications, as well as the areas of occupations affected and the role of an occupational therapist for someone with dysphagia. Adaptive equipment that may be utilized and some suggested foods to eat for someone with dysphagia will also be discussed in this presentation. Thank you.
Dysphagia is when an individual has difficulty swallowing foods or liquids. It is most common in the elderly population. Approximately 7 to 10% of adults older than 50 years old have dysphagia. 25% of hospitalized patients and 30 to 40% of patients in nursing homes experience swallowing problems. Additionally, 55% of stroke patients experience some form of dysphagia. In order to truly understand the significance of dysphagia, it is important to understand the process of swallowing. Swallowing is a complex process in which muscles and nerves work to obtain food in the mouth, prepare it, and move it from the mouth to the stomach. This is done in 3 phases: the oral, pharyngeal, and esophageal phase. In the oral phase, the tongue and the jaw are moving solid food around in your mouth so that it can be chewed. This is important because chewing turns solid food into the right size and texture for swallowing. In the pharyngeal phase, the tongue pushes the food or liquids to the back of your mouth, which triggers a response to pass the food through your pharynx, aka your throat. When this phase occurs, the larynx closes and breathing stops in order to prevent food or liquids from getting into your airway and lungs. In the esophageal phase, food or liquid is entering your esophagus and usually occurs in about 3 seconds, depending on the texture and consistency of the food. Sometimes it can take slightly longer, like when you're swallowing a pill.
Swallow 1 teaspoon.
Well, half a teaspoon, then 1 teaspoon. This is adult. Okay. Chin goes up. Right.
Go right ahead.
Multiple sips.
Really calm.
Okay. Here's the jaw.
Swallow, honey. Happen, but it's not nearly as fast.
Oh, okay, stop.
Yeah. Swallow. Swallow again. Swallow again. Swallow. He has no cough here.
Can you cough for me? Cough for me, James. Cough.
Look at there. Look at there.
Cough for me, James.
He's watching.
Cough.
Yeah.
Additionally, having difficulty in swallowing that occurs when you eat too fast or don't chew your food well is not really a cause for concern, but if it occurs persistently, this may be an indication that there's a serious medical condition that requires attention. Some medical conditions that are associated with dysphagia are cerebral palsy, a congenital disorder of movement, muscle tone, or posture, stroke, which is the damage to the brain as a result of blood supply to it being reduced or interrupted, head injury, Parkinson's disease, a disorder of the central nervous system that affects movement and often includes tremors, multiple sclerosis, a disease in which the immune system attacks the protective myelin sheaths and causes communication problems between your brain and the rest of your body, ALS, a progressive neurodegenerative disease that weakens muscles and impacts physical function, and myasthenia gravis, a chronic autoimmune neuromuscular disease that causes weakness in skeletal muscles, including the muscles that are responsible for breathing and moving parts of the body. Dementia is also commonly associated with dysphagia because as it progresses, swallowing becomes more difficult as it affects their sensory and motor abilities. There are 3 types of dysphagia, each one affecting a different part of the swallowing process. Oral dysphagia refers to the difficulty in the swallowing process due to issues regarding the mouth. This is usually due to issues with the movement of the tongue and efficiently pushing food towards the throat. This results in food sitting in the mouth and preventing food from moving on to the next step of the swallowing process efficiently. In adults, the symptoms of oral dysphagia can present itself in various ways. It can range from food simply remaining in the mouth after a meal, the inability to chew or swallow food, or even food and liquid simply spilling out of one's mouth. Some conditions or diseases such as head and neck cancer or cleft palate can sometimes involve themselves in the development of oral dysphagia.
Pharyngeal dysphagia is when foods and liquids do not move through the pharynx well and can be left behind after swallowing. This is because there is a decrease in the ability to trigger the actual swallow. Also, this type of dysphagia results in issues in closing the vocal cords, which results in food or liquids being misdirected into the airway during swallow and passing into the vocal cords, which is also known as aspiration. Pharyngeal dysphagia and oral dysphagia go hand in hand with one another, even having similar associated medical conditions such as stroke, multiple sclerosis, and Parkinson's disease. As a result, these two forms of dysphagia are oftentimes combined together and called oropharyngeal dysphagia. Some conditions associated with pharyngeal dysphagia are Parkinson's disease, stroke, ALS, also known as Lou Gehrig's disease, multiple sclerosis, and aspiration pneumonia.
Esophageal dysphagia occurs when food is not moving well through an individual's esophagus. It takes place in the esophageal phase of swallowing. It's commonly described as the sensation of food being stuck in one's throat or upper chest. Which cause damage or disease to the throat are comorbidities associated with esophageal dysphagia. These comorbidities can differ from the comorbidities associated with oral and pharyngeal dysphagia. The first is achalasia, which is when food cannot pass from your lower esophagus to your stomach. This can cause food to be brought back up into the throat. The next is esophageal stricture, which is a narrowing of the esophagus. Strictures can be the result of esophageal tumors, foreign bodies partially obstructing the esophagus, esophageal ring, which is the narrowing of a thin area in the lower esophagus, GERD, more commonly known as reflux, which can lead to spasm or scarring due to stomach acid traveling up through the esophagus. Other common causes include eosinophilic esophagitis, which is an allergic inflammatory disease of the esophagus, and diffuse spasm, in which the esophageal muscles involuntarily contract.
Some precautions and contraindications for individuals with dysphagia would be that it's important to maintain an upright position when eating or drinking, taking small bites to avoid choking, making sure that you're chewing food well and eating slowly, and you are to absolutely not lay down while eating or drinking or put large volumes of food or liquids in your mouth at once. Areas of occupation that are affected are activities of daily living, more specifically feeding and swallowing/eating. Social participation is also another area of occupation that's affected because clients may feel embarrassed or self-conscious to eat in front of others, so they avoid eating with peers and friends and tend to isolate themselves. Also, instrumental activity of daily living such as health management and maintenance is also another area that's affected due to the fear of eating, resulting in dehydration and malnutrition.
In the scope of the occupational therapy profession, dysphagia affects the quality of life in various populations, such as the pediatric, rehabilitation, and elderly populations. As a result, occupational therapists provide intervention in several settings such as hospitals, rehabilitation centers, outpatient clinics, long-term care facilities, schools, and in the home. Swallowing is an important activity of daily living because not being able to swallow negatively affects a person's nutrition, overall health, and as previously stated, one's quality of life. The role of an occupational therapist for a client with dysphagia is to provide focused interventions that will address a variety of swallowing issues. Throughout the following slides, we will discuss how OTs can help individuals live with their dysphagia by modifying the environment, educating the client and family members about best practices, improving and enhancing feeding skills by using adaptive tools, and by understanding the client's culture and personal preferences. Since many neurological diseases are associated with dysphagia, such as dementia, OTs can make mealtime easier for those with dysphagia by reducing distractions and limiting background noise. By following these procedures, risk factors related to aspiration become greatly reduced.
In regards to education, the role of an occupational therapist would be to educate and train caregivers in individualized feeding and swallowing strategies in order to improve their performance in eating and feeding. Also, it's important for an OT to modify and educate individuals about diet textures to promote safe swallowing and reduce the risk of aspiration.
Some examples of adaptive equipment used for an individual with dysphagia are nosy cups. These cups are used for people with difficulty swallowing liquids because they need to keep their chin in a more neutral position. This can also be used for people who have difficulty swallowing as a result of not being able to tilt their head back due to neck pain. So this cup really helps in allowing you to bring the cup closer to your face so that you're not really tilting your head back all the way. The ProVail cup was designed specifically for people with dysphagia or have a swallowing disorder. This cup provides a fixed amount of thin liquids and small sips. As a result, this cup prevents over-delivery of liquids and promotes safer swallowing and more independence for individuals.
Utilized are the maroon spoon and the mid-E spoon. The maroon spoon can be used so that clients are taking smaller bites and because it is light and will reduce fatigue when eating. The mid-E spoon may be utilized in order to help clients having trouble with mixed consistencies. This spoon separates solids and liquids such as cereal with milk and soup.
Other occupational therapy interventions consist of conducting preparatory activities before a meal to facilitate oral and pharyngeal motions that are needed for eating and drinking, positioning the client's body that will allow optimal digestion and use of the arm, reinforcing adapted swallowing techniques, and creating mealtime routines.
Back in 2003, a national diet plan was created to help those with dysphagia consume food properly through texture modification. The NDD, or National Dysphagia Diet Plan, was developed through consensus by a panel of dietitians, speech-language pathologists, and a food scientist. There are 4 levels of semi-solid to solid foods that were proposed in the NDD. Level 1 pertained to foods that are pudding-like and require little chewing ability. Level 2 pertained to foods that were moist and similar to Level 1 but required some chewing, examples being peanut butter, scrambled eggs, mashed fruits. For Level 3, the permitted foods were soft to solid foods that required more chewing than Level 2, and these foods were certain meats and vegetables that were easy to cut or mash. Both Level 2 and 3 avoided snacks or foods that were difficult to chew, such as chips and crackers, and Level 4 involves all forms of food.
As an occupational therapist, it is so important to obtain a well-rounded understanding of a client with dysphagia, such as what foods are within their culture, their personal preferences and feelings about mealtime and feeding, showing clients how to use computers to look up recipes or menus of the foods that they typically enjoy. And this is all in order to develop a client-centered treatment plan that not only improves their ability in feeding and swallowing, but so that clients are also motivated to feel confident in participating in their mealtime routines.